And we're back with Rodrigo Scattone. Is that how you pronounce your last name?
Yeah, that was good. That was good.
Nailed it. All right, Rodrigo, this is your first time on. I'm pumped for this conversation. For people that aren't familiar with you or haven't heard of you in the past, can you tell us about yourself and what you do?
Sure. Thanks for having me, Chris. I'm a physical therapist. I was born and raised in Brazil. I specialize in sports physical therapy, and I got my master's and my PhD here in Brazil. Treating patients with patellar tendon pain, I just started to get really curious about how the kinetic chain factors affect patellar tendon pain and how little in the literature we had on that. So I just decided to do a PhD on that topic. Um, During my PhD, I got a scholarship to go to Australia. I went there. I conducted part of my studies at the Australian Institute of Sport. It was a fantastic experience. Professor Craig Purdon welcomed me with his group there. Everybody who reads tendinopathy literature knows Craig. He's co-author with Joe Cook in several classical tendinopathy papers, like the Continuum paper. He's been doing research for 30 years. He's been involved in 5 Olympic Games. He's such a legend. It was a phenomenal experience to stay there with him for almost a year. Then I came back, finished my PhD, and then I got a position at a university in the northeast coast of Brazil, which is where I live now. I've been an assistant professor here for almost 9 years, and I teach sports physical therapy. I supervise clinical rotations of the students in their last year of physical therapy school. And I conduct research. I supervise master's degree and PhD students in our physical therapy graduate program. In 2021, I went to the US to do a research collaboration with Professor Karen Subernagle, which I'm sure your audience knows very well. She's amazing. Such a great experience with her too. While I was there, we conducted a study to look into the load progressions in patellar tendon. We teamed up with Assistant Professor Josh Baxter at the University of Pennsylvania, and we did a study there on loading progression tiers for patellar tendon. And finally, last year I went to Copenhagen as well. I did a research collaboration there with Professor Peter Magnussen and Professor Michael Kjær at the Institute of Sports Medicine of Copenhagen. And for those of you who are not recognizing the names, these are the researchers who came up with the heavy low resistance protocol, the one that we use a lot for tendinopathy rehab. So yeah, I was fortunate to learn from some of the best, and I'm very much looking forward to our conversation today.
Yeah, little did I know before we get on this call that and we'll link it, our previous conversation with Karin and Josh Baxter was discussing your paper. And I guess I remember the last name Silva, but I didn't put 2 and 2 together with that being yourself. So it's great to now have you on. And we're going to dive into Achilles tendinopathy. So we've had previous discussions with a variety of guests, such as Karin, Ruth Chimenti, more recently discussing the GOSPT clinical practice guidelines, yep. Jake Tura, Miles Murphy. But this beast of a paper or review just came out of Nature, these Nature Reviews disease primers, which I've never heard of. Is this just 2025 that these started out of Nature? Do you know, or they've been going on for a while?
Yeah, they've been going for a while, and they typically involve medical conditions. So you see a lot of them for really serious cancer conditions, and they're typically state-of-the-art papers, and now they're diving more into the musculoskeletal conditions as well, which is great.
Yeah, that's what I thought. I looked at the others for 2025 and saw one on osteoarthritis that I want to dive into. Yeah. But this Achilles tendinopathy piece came out a month or 2 ago at this point, and it's a beast of a paper, and I thought it was awesome. And you were one of the authors. So can you discuss really what the goal of these primer papers are and what your role was within this paper?
Sure. So the primers are state-of-the-art papers, like I said. So the purpose here is to provide clinicians and researchers with a thorough overview of the epidemiology, pathophysiology, diagnosis, management, and the latest advances in treatment for this condition, both non-surgical and surgical interventions. So I was in charge of the management section. So they invited me to lead that section. I was privileged to have several really great co-authors with me on that section. So I had Alex Scott from Canada. He's a professor at the University of British Columbia in Vancouver. He is one of the biggest experts in the world in secondary tendinopathies associated with metabolic conditions. He was really great. He has some really great papers on JOSPT about that. And it was really nice to have him with me in that section. And then we had two surgeons from New York, James Butler and John Kennedy, also helped us with the surgical management part. And I was also a collaborator with the diagnosis, screening, and prevention section. I think that's the name of it, which was led by the brilliant researcher from Belgium named Evie Wizenbeek. She is phenomenal. She's been doing really great research on insertional Achilles tendinopathy lately. And we wrote that section together. I addressed more of the clinical assessment part, the tools that we should use to assess the different domains of tendon health, the differential diagnosis, and so on.
Yeah, one thing that I've found super impressive about the piece, out of many things, but the picture and the differential diagnosis discussion that I really want to dive into today. And in previous Achilles tendinopathy episodes we haven't touched on it a ton. So I think this paper really brought to light discussing this. And because tendinopathy now is just kind of a hot topic to talk about, I think it's worth discussing. Not everyone presenting with pain around the heel or the Achilles is always an Achilles tendinopathy. So I really want to dive into some of those differentials today. But before we dive into that, can you just define Achilles tendinopathy, and if you want to subclassify or create the difference between the insertional versus the mid portion?
Absolutely. So Achilles tendinopathy is a condition that involves pain in the Achilles tendon, localized pain in the Achilles tendon that is related to loading. So if you do any activity that loads the Achilles tendon, like walking, heel raises, going up and down stairs, running, jumping, you have a very localized pain in the Achilles tendon, whether it's in the mid portion or in the insertion. You have a suspicion that you might have an Achilles tendinopathy. So it's an overuse condition that affects the Achilles tendon. It causes localized pain in the tendon associated with mechanical load. That's the basic definition of it. Then we have the specificities of if it's metabolic related, if it's insertional versus mid portion. You have a few classifications, but the main definition for clinicians listening, if it's pain in the Achilles tendon is localized and is associated with load, you have the potential of being an Achilles tendinopathy. You should do a thorough assessment to see if that's the case.
Yeah, I was going to ask this later on in the conversation, but maybe it makes sense to bring it up now. In the paper, you all discuss this primary tendinopathy versus a secondary. Can you discuss what that means between primary and secondary?
Yeah, sure. So that's a concept that was initially brought on by Alex Scott from Canada. So he's the main researcher that I know that looks into that. The initial publications that came on that specific topic are from his group. The 2015 paper on JOSPT is the main one that I would recommend for anybody who wants to see the different distinctions between metabolic-related tendinopathies versus overuse load-induced tendinopathies. But just to give you a direct definition, so a primary tendinopathy would be a tendinopathy that is related to overuse. So excessive load in the Achilles tendon provoking an overuse condition that causes pain in the structure, alterations in the structure and causes pain. That's a primary tendinopathy. When we talk about a tendinopathy that has been caused by something else, any other medical condition causing pain in the Achilles tendon, you also have a tendinopathy, but now we call it a secondary tendinopathy. And that's an important distinction because people will have tendinopathy associated with diabetes. They will have tendinopathy associated with hypercalcemia. They will have associated with any medical condition that causes an alteration of the homeostasis of the tendon and causes overuse is called a secondary tendinopathy. So you can have tendinopathy from using medications such as antibiotics. You can have it from having a very prolonged case of hyperglycemia secondary to a type 1 diabetes. And obviously the management of these patients is not going to be the same when you compare it to somebody with a primary tendinopathy. So that's why we had a very strong emphasis on making the distinction in the paper and calling attention to that, because that's a very often neglected topic.
During those secondary tendinopathy cases, is it more common for those to present bilaterally, or is it still the most common to be one Achilles at a time? Does that show differently?
Yeah, that's a great question. Sometimes we see it bilaterally. but it's not unusual for you to have it unilaterally when it's also associated with some kind of overuse. So when people talk about metabolic related versus load related tendinopathies, we have to understand that it's not one or the other. They both contribute to causing the overuse, but sometimes the weight of one of the issues is greater than the other. And in these cases, when you do an overuse for your, let's say your dominant shoulder is being overused because you're working very often using that shoulder, and you also have diabetes, you will have or often unilateral tendinopathy on that shoulder associated with your diabetes, but also associated with load. Whereas if it's in the Achilles tendon, which typically suffers from bilateral issues like you run too much, or you're walking up and down, you're walking greater distances than you're used to, and you also have a metabolic issue, in those cases you often will see it bilaterally. But it varies, but for tendons that are often loaded symmetrically, you will see it bilaterally.
And then cases that are rheumatological in nature, where there's tendon-related pain in the Achilles region or the elbows or these other tendon locations, would that also be considered secondary, or is that that's its own category where it's not a true tendinopathy, but it's tendon pain from an actual kind of rheumatological or autoimmune condition?
It also falls into the category of secondary tendinopathy. You see that in Alex Scott's paper. He mentions those specifically. There's a beautiful table in the paper that mentions all cases, and the rheumatological conditions are still one of them. So it's not uncommon for you to have an enthesitis or an enthesopathy in people who have rheumatological conditions. And then the underlying condition is the rheumatological condition, but you also have a tendinopathy associated with that condition. So it is a tendinopathy, but also related to something else. And that's why we emphasize that the management can never be the same as somebody who has a primary tendinopathy.
Yeah, I'll link that paper so that people can dive into that further as well. The differentials that y'all include within the paper, outside of the ones we've already mentioned, and this is where kind of this picture or variety of pictures come in on the location of other pain locations and potentially what the diagnosis may be outside of an insertional or mid-portion Achilles tendinopathy. So I kind of want to just go through the list. Some may take longer than others, but I'm curious, if there's potential other diagnosis that's likely found outside of a tendinopathy, how much will it actually change management? Is imaging required? And some of these things that clinicians should maybe consider. So the first one outside of the insertional and the mid portion that y'all have is a posterior impingement classification or diagnosis. How would clinicians find or have a higher probability that a posterior impingement may be a more likely diagnosis than a tendinopathy?
Yeah, that's a great question too. It's very important for us to understand that if you don't do a thorough assessment, there's a big chance that you will treat somebody with the wrong diagnosis or make bad decisions, not because you're not doing an appropriate treatment, but because you're treating the wrong condition. So I mention this all the time when I'm teaching classes. If you have an elbow pain, lateral elbow pain, and you didn't assess your cervical spine, you didn't assess doing neurodynamic tests to see if it isn't the radial nerve, if it isn't somebody who fell on their outstretched hand and has a posterolateral instability of the elbow and has a partial tear of the ligament, and that's what's causing their lateral pain, and you treat that under the umbrella diagnosis of lateral epicondylitis, you're going to have a bad result, not because you're doing a bad treatment, but because you're treating the wrong condition. So we have the same thing here for the Achilles. So it's very important to do a thorough physical exam, a thorough clinical examination, looking into the history of the patient to see are there any causes to their initial symptoms. Is it an overuse condition, or is it associated with a trauma? What the patient thinks, what is his belief that the pain is associated with. And then we do a very thorough physical exam to see the differential diagnostic tests. So for instance, one test that is very important is for you to do passive plantar flexion of the patient with him in prone lying, because if you do passive plantar flexion and that reproduces their pain, you're actually unloading the Achilles. You're reducing the load because you're doing a passive plantar flexion, and you're actually causing compression in the posterior aspect of their ankle. So if somebody has an os trigonum, like an additional bone in the posterior aspect of their ankle, if it's like a ballet dancer, is that how you pronounce it? Ballet dancer? It's a hard word to say
you nailed
in
it.
English for a Brazil. Okay. So if she's a dancer and she's doing a lot of plantar flexion, really high load activities, she's getting sometimes impingement in the posterior capsule of her ankle. And then when she goes up in her toes, she has pain. And then you say, well, posterior ankle pain associated with plantar flexion with load, Achilles tendinopathy. Not necessarily. You have to do a passive plantar flexion to see if that reproduces their pain. The pain is a little deeper usually. It's not very superficial. It's not localized in the Achilles tendon. So that's just one example of how important it is for you to do a thorough assessment. If you manage these patients thinking it's an Achilles tendinopathy and you do end range plantar flexion exercises, you're just compressing even more the posterior aspect. So this is a classical example of somebody who's actually trying to help, but it's not getting good results because you're doing a wrong treatment, because you're treating the wrong condition.
Yeah, that's super helpful. And I guess to caveat with a variety of these, two things can be occurring at once. So someone may have an Achilles tendinopathy and some of these other differentials may also be present. And that's also where it gets messy. But to the posterior impingement, the kind of prone passive plantar flexion testing, if there's that pain or discomfort in that area they've described, it doesn't make sense that it's an Achilles tendon, like you said. They're not in a loaded, stretched position of the Achilles, and maybe palpating the Achilles itself is not painful. They're describing it as a little bit deeper. To that point of, let's say it's a ballet dancer or someone where they're noticing symptoms at end range plantar flexion, what would be maybe changes in management strategy? Is it just minimizing some of those end range positions for a while? Is there surgical management? What does posterior impingement, in summary, kind of look like outside of an Achilles tendon management option?
Absolutely important to check if it's a condition that is happening at the same time, like you mentioned. So if you have an Achilles tendinopathy and a posterior impingement at the same time, you would have to treat both conditions, but you have to be mindful that the treatment for one might interfere directly with the treatment of the other. So that's very important to highlight. But if you have a posterior impingement, what you have to be mindful of is there are several causes for that. One cause is just a thickening of the posterior capsule because of repetitive trauma to the posterior capsule in plantar flexion, forced plantar flexion. So if you have that, just by removing the stress, removing the provocative activity, you already have a substantial improvement in symptoms. And then it's just a matter of graded exposure to the activity again. So you just go back to doing the things that you want to do. But if you have a bone, an os trigonum, that is an accessory bone that some people have in the posterior aspect of the ankle, then you have to look it up if that's not really causing compression every time you do plantar flexion, because that might be an important limitation for some people. So if it's a ballet dancer that needs to be all the time in plantar flexion with high load, if every time she's compressing her accessory bone, maybe the surgical management will be necessary there. But if it's a combined condition, if you have Achilles tendinopathy and a posterior impingement, what we do differently is we avoid the end range plantar flexion in the exercises. So it's the opposite of an insertional tendinopathy where you would avoid dorsiflexion. Here you would avoid the end range plantar flexion. You would do exercises from maximal dorsiflexion to maybe mid-range plantar flexion, progressive loads to get the structural adaptations in the Achilles tendon, but without provocating the posterior impingement symptoms.
Next one, the Haglund or calcaneal exostosis. What would clinicians be cluing in on or noticing if this is a potential differential?
So yeah, that needs imaging to be assertive in determining if that's what's causing the insertional Achilles tendinopathy. But when you have a Haglund or an exostosis, what you have is you have a bony prominence in the calcaneus, in the posterior superior aspect of the calcaneus. And that what that does is it just causes more compression of the Achilles against the bone. So whenever somebody does dorsiflexion, you're going to have more compression of the Achilles against the bone. And we know that compression is one of the causal factors for insertional Achilles tendinopathy. So it just makes it harder for you to manage. You sometimes have to work with even more strategies to avoid dorsiflexion using heel lifts. Sometimes even that is not helpful. You have to really remove the load for any dorsiflexion load, any even neutral position loads in the beginning, so that the patient actually has some level of improvement. They have to wear really high heel lifts so that they don't have any compression at all. And the conservative management mostly involves trying to remove compression at all costs in the initial stage, and then gradually reintroduce the compression in the intermediate and advanced stages. Some cases are surgical. If you have too much compression, even with 6 months, 1 year of conservative treatments, doing a very well-conducted intervention, you still don't get the good results. In some cases, you might need to do an excision, a surgical excision of the bone, and then you reinsert the Achilles tendon, and then you have to do a rehab similar to a rupture in the post-op. But that's the main differential, the main difference between the management of somebody with a Haglund in relation to somebody with a classical tendinopathy.
Subtalar joint pain, similar frame. What are we noticing if it is potentially subtalar joint pain?
Yeah, you would see that the location of pain is different. So they don't really have the pain in the Achilles tendon. It's usually medially and laterally. And when you assess your patient in the passive treatments, in the passive movements, like I said, you do passive plantar flexion to see if that causes their pain. You also stabilizes the talus, and you do a calcaneal movement in the inversion and an inversion of the calcaneus. And if that reproduces their pain, the Achilles tendon is again relaxed, it's not under any load, but moving the subtalar joint causes the patient pain. We often talk about this. It's reproduction of the patient's symptoms that we're looking for in the special tests. It's not just, is it painful? Is it not painful? Is this your pain? Is this what causes? Is this what you usually feel when you're doing your sports, your activities? If you get a reproduction of the patient's symptoms by moving the calcaneus in relation to the talus, it's most likely a subtalar joint issue, degenerative issue, most common in older patients, or athletes who really overload their joints from a very young age and then develop those degeneration problems in the joints. Those are the typical patients that you'll find. But the pain location is different. So basically, the pain is more medially and laterally instead of just in the tendon. And you have pain reproduction with movements of the subtalar joint.
And then management strategies there, is it the same thing for the past two of minimizing provoking activities or positions and allowing things to calm down and eventually working back into them? Is there much that can be managed?
Yeah, usually you will be worried about excessive pronation in this case. So excessive pronation was considered the biggest villain for musculoskeletal injuries in the last decade. So now every time I talk about this, I try to be careful so that people don't go back into thinking, oh my God, pronation is the root of all evil. But pronation can be relevant in some cases. And if you have subtalar joint, if you don't remember, the movements of pronation and supination occur in the subtalar joint. So you have plantar flexion of the talus, adduction of the talus, and eversion of the calcaneus as the movements of pronation. So if you have excessive movement there, and the patient is relying too much on that movement to dissipate load in comparison to the plantar flexion and dorsiflexion, they have dorsiflexion restriction, they don't have a good hip and knee strength, they're using their joint to dissipate the load, you're going to have an overuse condition for the joint. So I would definitely address the kinetic chain factors in these people. I would often strengthen the tibialis posterior in these people, trying to get it to work better, to lift the longitudinal medial arch. Those are all conditions that we would be, those are all aspects that I would take into consideration managing these patients. Some patients might need plantar orthosis, some kind of support in the medial aspect of their ankle. You really have to assess the patient to see what works for them. But what I usually do is I see if that modifies their symptoms. If I put a foot orthosis and that modifies their symptoms during heel raises, that's usually a sign that it might be indicated in the beginning. But I would be very careful with recommending those for everybody with Achilles tendon pain or ankle.
Why would you be very careful with that?
Oh, because again of the main emphasis that this has received in the last decade. Everybody was prescribing foot orthosis for everybody. Pronation was the source of all problems, and people would just recommend that without even assessing, without even seeing if that changes symptoms, and without addressing the rest of the issue. So it's very nice to see, if you look at the previous papers on Achilles tendinopathy, one like 1984, there's a very nice paper, Achilles tendinitis, etiology and management. You see pronation as being considered the main cause of Achilles tendinopathy. And they mentioned that you have to use foot orthosis for patients for them to get better. Ice massage. You see a big shift from the literature from back then to here. But a lot of things have stood the test of time, even though the evidence doesn't support it. So people continue to do treatments because they saw somebody saying on social media, and the evidence doesn't really support it. So sometimes it makes sense to use it, but be careful with prescribing that for everybody.
The next two may be easiest to clump together. Two separate types of bursitis, a retrocalcaneal bursitis and a superficial bursitis. Obviously, they're two separate things, but from a bursitis aspect, how would you be cluing in on those two?
So the bursitis would be, typically the patient would have a thickening of the posterior calcaneus. So you look at their calcaneus and you have a very thickened insertion. You need imaging to actually rule in bursitis, to confirm that it is a bursitis. You have to have accumulation of fluid in the bursa to say that it's a bursitis. They're more often associated with really chronic conditions, or with conditions where you have a direct blow to the ankle. So if you have a direct trauma to the posterior aspect of your calcaneus, since that's a tissue that is very important to dissipate compressive loads against the tendon, it will get very irritated if you have a very strong blow to the calcaneus. So it's important to do imaging, ultrasound imaging of those patients if that's the case. Their pain is usually a more diffuse pain in the calcaneus or in the medial and lateral aspects of the calcaneus if it's bursitis. If we have that, I usually send the patient to get an imaging, or we also have ultrasound now. So you can also look into, in your clinic, if you have ultrasound, if there's any bursitis there. If it is, you will, if it's associated with a trauma, you will just reduce the inflammatory signs, because in this case, you do have a bursitis. It is an inflammation of the bursa, but then obviously you treat it as an insertional tendinopathy if that's the case, or sometimes just by reducing the inflammation caused by the trauma, you just resolve the problem. But if it's a chronic case with bursitis in the calcaneus, we try to reduce the compressive loads in the tissue, because that's what irritates the bursa. And then we progressively load the tendon so that the patient gets back to doing what they want to do.
Sever's disease, what is that? And then population-wise, who are we cluing in on, and maybe age, who gets this?
Yeah, it's a condition that is associated with the growth spur in adolescents. Children, usually. Children will have Sever's disease. You will see this very common in people who are physically active. They're doing a lot of jumping, running, and they develop a pain in their Achilles region, in the calcaneus region. It's also called calcaneus apophysitis. You might have heard that. It's a disease of the plate, the cartilage plate that you have there that's not yet calcified. So if you have too much jumping, too much running, too much tensile stress in the Achilles, in an area that's still not completely calcified, in a growth plate that's not yet calcified, you can get Sever's disease. The difference usually is that's associated with growth spurs. So you always see this in children/adolescents in the transition stage where they're still developing. You're not going to see that in adults. So the profile of the patient here is important. We have a little bit of research on that topic. For the longest time, this was treated with immobilization, that the physicians just would give them an ankle boot and they would stay there for like a few months, which was very detrimental for the tendons. Nowadays, we're trying to walk towards a more active management approach for Sever's disease. A big shout out to my good friend Sean Haglund, who was a PhD student with Karn Silbernagel while I was there. He's one of the researchers who's diving deeply into Sever's disease to see if we can manage them more likely to what we do with an insertional tendinopathy. which is quite challenging because children don't really want to do loading exercises the same way as we do for adults. But they're doing fantastic work on that topic to see how we can best manage those patients.
This is kind of a pivot for temporarily, but what's the reason, or do we know why youth and adolescent individuals don't get tendinopathic or tendinopathy pain? And if anything, it's this attraction of apophysitis at, the Achilles or the calcaneus, or with Adjunct. Why is that?
We don't really know, actually, Chris. That's very interesting. We thought that they only had the pain in the apophysis and in the cartilage growth plate, but Sean's study is actually showing that several of them actually do have tendinopathy. If you actually look at their tendons, it's very similar in terms of alterations in structure to somebody who's an adult with tendinopathy. You see thickening of the tendon, you see fluid accumulation, you see hypoechoic areas in the tendon. So it's not just the cartilage that should be blamed, the growth plate that should be blamed for the symptoms. We should be doing a thorough assessment. We should be imaging them to see if their tendon is the source of the symptoms, if we can say that. But if it's not just the cartilage that is causing the pain, but also the tendon. But what we do, what we have been emphasizing in the last few years is we don't really want them to do immobilization anymore, although that was the gold standard treatment for that condition in the last few, 10, 15, 20 years. Nowadays, we're trying to move towards a more active intervention so that we don't have to deal with the several consequences of immobilization that the tendons have after a short period of time of immobilization. You already have a very substantial decrease in their capacity to tolerate load. So these patients will have a massive atrophy in their calves, massive alteration in their structures of their tendon just because they stayed 2 weeks immobilized. So we're trying to move away from that and we're trying to do science, do research to see what works best for these patients.
We had a really great episode a year and a half ago with Angie Jackson discussing Severs and Adjunct, and very much a push towards staying as active as possible, but maybe minimizing some of the most aggravating activities. So if people want to dive further into Severs or these, apophyseal based injuries, go episode 132. Check that out. Calcaneal stress reaction or stress fracture. What are we cluing in on?
Yeah, that's a tough one. You will see that in really, really high level athletes that are overusing their condition, like ultra marathon runners, somebody who's really doing a substantial amount of load in their musculoskeletal system. And then we don't really know why, but some people develop stress fractures in different regions. Some people develop it in the fifth metatarsal. Some people develop stress fractures in their hips, sometimes in the sacrum. Sometimes they develop in the calcaneus. And we're not sure why that happens, but some people will have a stress fracture in their calcaneus. What we're looking for here is, where is their pain again? So if their pain is actually more medial and lateral in the calcaneus instead of in the insertion of the Achilles, if that is associated with a very high intensity of load for a very prolonged period of time, that's somebody who I would consider eligible to doing an exam, an imaging exam, to see if it's not a stress fracture.
And we've had multiple previous guests talk about the management depending on the site of the stress fracture, the grade. So for people who want to dive further into that, just go look up stress fractures or higher low risk with previous episodes, and we have a ton on management there. Next one, Plantaris tendinopathy.
Yeah, that's a tricky one. The Plantaris is a tricky muscle that we have, and we still don't know what it does up until this day. Some people say it only serves us to get grafts, but it also causes a lot of headaches for us sometimes, because the Plantaris is a very short muscle that we have in the back of your knee, and then it has a ginormous tendon that goes all the way down until your calcaneus. That's your typical insertion of the Plantaris. But what a lot of people don't know is that the Plantaris sometimes actually inserts in the Achilles. So instead of inserting in the calcaneus, some anatomical variations, you have the Plantaris inserting in the Achilles medially. So what you have there is whenever it contracts, it pulls the Achilles and it compresses the Achilles against the Kager fat pad. So you have compressive stress in the medial side every time the plantaris contracts. And then you have a plantaris associated tendinopathy. And we didn't know that until very recently. And now Håkan Alfredsson, who is the Swedish doctor who came up with the eccentric famous protocol for Achilles tendinopathy, he's the one person that I know that is doing really good research on that topic. Him and Lorenzo Massi, Dr. Lorenzo Massi, who's a collaborator of his, they're doing research in seeing how can you do a surgical intervention that is very specific, just an excision of the plantaris tendon, and you see massive improvements in their patients. You see ultrasound tissue characterization, that UTC, that ultrasound that is it colors the tendons in 4 different colors: red and blue if they're very well aligned, and black and red if they're very disorganized. If you look at their papers, you see a very black and red area in the medial aspect of the tendon when you have a plantaris tendinopathy. And then after the surgical excision, a few weeks of rehab, you have a beautiful green and blue tendon after just a few weeks of intervention after the surgery. So it's one of those cases where surgery should be considered. Sometimes we try to manage it conservatively, but it can be tricky. It's harder to evolve. We have a hard time going past the second to the third stage. Introducing high velocity activities is very often symptomatic for these people. So it's kind of tricky. And just to be clear, how do you differentiate if it's a plantaris or a typical Achilles tendinopathy? The pain is very medial. So if you look at the image that we put in the paper, you look at the tendon, Achilles tendon, medial side, it's a very medial pain, doesn't hurt in the lateral side, doesn't hurt in the tendon as a whole. It's a very medial pain in the Achilles. If it's that, I highly encourage you to do an imaging exam to see if there's no plantaris there. If the plantaris is there, you can try to continue with the conservative treatment for more time. But if you don't have a good result, that's the patient that would be eligible for a surgical management.
On the opposite side, on the lateral side, sural nerve neuropathy. What's going on there?
So the sural nerve is one of the branches from the ischial nerve. So the ischiatic nerve, I'm not sure if I'm pronouncing this right because I'm not used to speaking in English with that topic specifically, but I guess that's the name. So it's one of the branches of that nerve, and it goes laterally. And then once it goes laterally, it passes through the very close to the Achilles tendon, and then it innervates the lateral aspect of your foot. So the sural nerve, it can be compressed in its trajectory when it's going down, and in some people it gets compressed in the distal shank, and then once it's compressed by connective tissue, it can cause symptoms in the lateral aspect of the foot or in the lateral aspect of the Achilles. So it's important to do a thorough assessment here again. I typically do in the clinic the neurodynamic tests. So I do the slump test with dorsiflexion in inversion, which is a variation of the slump test that stresses the ischiatic nerve, but also puts more strain, more tension, I should say, in the sural nerve because it passes posteriorly to the malleolus. So dorsiflexion with inversion will tension it more. And then if you have a reproduction of the symptoms of the patient with the neurodynamic test, then you have the potential for having a sural nerve problem. Again, the symptoms will be different. So they won't have a typical Achilles pain. They will have pain associated with nerve compression, which would be tingling. It would be sensation alterations, paresthesia. You won't have the typical pain again. But because it hurts close to the Achilles, a lot of people will be misdiagnosed with Achilles tendinopathy. So keep your eye open for that.
Paratenonitis, or a partial tear of the tendon. How do we differentiate that between a tendinopathy?
Yeah, that's hard. That's harder. If it's a partial tear, usually it will be associated with a very distinct mechanism. So typically people who tear, they will have a very high velocity activity associated with their pain, unless it's a chronic case where you have partial tears associated with a degenerative tendinopathy. And these cases are very challenging to establish too, because we were in the last consensus. I think, no, it was before that one. The last one was in Valencia. The one before that, it was in the Netherlands. And then there were a lot of radiologists in the audience, and we asked them specifically, can you very well differentiate a partial tear to a degenerative tendinopathy? And they said, no, we cannot. It's in the ultrasound is very, very similar. It's a hypoechoic area. So usually what we do is we distinguish that by the mechanism. Was it a very high velocity activity that caused a nagging pain in the Achilles? We look at the imaging, we see a very significant alteration there, probably a partial tear. If it was a degenerative condition for a long time, it might just be a degenerative tendinopathy, not really a partial tear. But with regards to the paratenon, now we will see the overuse being associated with the plantar flexion and dorsiflexion movement. So it's not so much the load in the tendon itself, but the friction between the tendon and the paratenon. So in those cases, you get the pain reproduction with dorsiflexion and plantar flexion in high range of motion, in a very long range of motion, not so much with the load. So if you have somebody who's doing a very frequent repetitive movement of dorsiflexion and plantar flexion, even if it's not with load, they might have excessive friction between the tendon and the paratenon. And then that's the kind of activity that we will have to decrease in the management. So if that's the case, you have to reduce the excessive movement in large range of motion to allow the paratenon to settle, to reduce, in this case, the inflammation, because it's a paratendonitis. It's different than a tendinopathy. Then in this case, anti-inflammatory agents might be useful. Ice might be useful. This is a very specific condition that you might be able to have good results with anti-inflammatory management in relation to a classical tendinopathy.
This is timely because yesterday in the clinic, I had an eval with an individual that was referred from podiatry, and the referral said partial Achilles tendon tear. Ordered a boot for this individual. She came in, she had an insidious onset of symptoms. It's been a year. Did imaging about a month ago with his podiatrist. Made the note that there was a partial tear of the tendon. I asked her, how long were you recommended to be in the boot? And she said 5 months. And it's this balance of, okay, day one, I do not want to go against this individual's, referring provider, but no acute mechanism. It's been going on for a year. I did a physical exam. She has full range of motion. She can tolerate double leg heel raises for 20 reps. Probably could have done 2 times more with no symptoms. And, it feels shocking how conservative that is. But at the same time, in the referral, it says prescription eccentric loading. So I'm like, okay, this podiatrist wants me to do eccentric loading, but he's also providing a boot for 5 months. It just doesn't make any sense. So anyways, I'm gonna reach out to this podiatrist and get some more information and have a discussion. But I'm glad that's what you're discussing. When it's this kind of degenerative, insidious onset, it's a degenerative tear. It's hard to differentiate. Is it a partial tear? Is it a tendinopathy? It's probably likely going to be managed similarly. I'm assuming that's kind of what you're alluding to. That's concerning. Does that happen, or do you hear about that often, where there's findings of a partial tear, but it's not an acute mechanism, and people are placed in immobilization or cam boots?
Yeah, unfortunately, yes. We see that all the time. And the recommendation is immobilization. And can you imagine the catastrophization that the patient goes through when he hears that he has a partial tear? Immediately, there are some studies, qualitative studies looking into that now. But they immediately think that they had a rope, and now they're only hanging by a thread. They cannot put load. If they do anything load related, they might rupture the tendon abruptly. So they're very fearful of moving. They don't want to do any load related interventions, and it's just based on the label, the name of the condition that was given to them. When they get back home, they Google it, they see it, they oh my God, I'm gonna die, 6 months to live. Some people will do a very strong catastrophization. That's a hard word for me again, but they will catastrophize a lot because of hearing a word that they don't really understand. They weren't given proper education associated with the diagnosis, and then somebody tells them that they have to wear a boot for 5 months, which doesn't really make sense to wear a boot and do eccentrics at the same time, but I'm not going to get into that. But the main issue that we have is to undo the damage that was caused by them. So education takes a long time in our sessions to try to reverse the damage that was caused by a less than ideal communication, I should say, to be polite, in the initial addressment of the condition that they had. But yeah, that happens very often, and I'm hoping that we can change that in the future. I'm hoping that by doing more and disseminating our knowledge more and being better at doing the knowledge translation in social media and YouTube and whatever, we get the message out that tendons need load and that immobilizing makes no sense, and that we can't really differentiate a partial tear then in relation to a degenerative tendinopathy. If it's a partial tear, the treatment is conservative anyway. It's going to be progressive loading. So we shouldn't be really catastrophizing our patients saying that they have a partial tear. It's just some things that are always in my mind the last few weeks and last few months, and we're trying to do our best to change that.
Yeah, and that it's just sad because there's these cases not just at the Achilles, but at rotator cuff tendons. There's found partial tears or even full thickness tears that are, age related or just changes over time. Degenerative meniscal tears, osteoarthritis that's described or fear mongered as bone on bone, and it's hearing what patients are worried about and asking, what did your provider, your surgeon explain to you what this means or this imaging finding? And it almost always falls short or flat, or is just so black and white and does not provide that sentiment of reassurance of, we have strategies to manage this. This may sound scary, but this is actually what it means. It's less scary than it actually sounds. Like, it's an uphill battle because, like you said, these things may be ingrained either acutely or for years or decades. They may have heard or believed this about their body or parts of their body. So it's challenging. Okay, we'll get back on track. The last one, accessory soleus muscle symptoms.
Yeah, that's tricky too. A lot of people don't know that, but in a small percentage of the population, you have an accessory soleus muscle. So it's less than 5%. I don't remember the exact number, but I think it's around 3% of people have that. So you have an additional muscle that is more distal, and it sometimes causes pain in the anterior aspect of the Achilles. So it's close to the fat pad, the Kager fat pad in front of the Achilles. You have a pain that's not very localized, it's more diffuse. You should be looking into if there's no soleus, accessory soleus muscle there. So you do imaging. Typically, either an MRI or an ultrasound will pick up an accessory soleus muscle. It's, like I said, it's rare, like less than 5% of people, more around 3% of people will have that. So it might be something to keep your eye open for if the pain is not your typical Achilles tendon pain. If it's a more anterior pain, more diffuse Achilles anterior pain, think about maybe doing a differential diagnosis using imaging to see if it's not the accessory soleus muscle.
All right, we made it through. That was super helpful. And really, I wanted to dive into that because, again, we didn't have previous episodes really laying that out. And I think that's super helpful for myself selfishly and hopefully for other individuals. Other episodes, we've done a deep dive into management strategies, primarily being this education, reassurance, and appropriate loading. And you all mentioned in the paper there's still not one size fits all loading protocol, and there's a lot of roads that lead towards being helpful. So I'll kind of keep that there. As much as I'd love to dive into that with you, I think other people in other episodes can listen to those conversations. I do want to dive into some of these adjunct treatments because I think, again, this paper did a great job. It's table 3 discussing some of the adjunct treatments and what the evidence suggests and when people should or should not consider some of these options. We'll go, I think there's kind of 4 main areas: electromodalities, injections, topical treatment, and NSAIDs. And maybe on the 5th, we add in surgical options. Electromodalities, you all had 3: focus shockwave, radial shockwave, and laser therapy. What would the evidence suggest for any or all of those 3, and when should patients consider them, if at all?
Yeah, that's good. So just one quick comment about the exercise management. We don't have one exercise management that is superior to others. That's very important to point out. There was the wave of eccentrics, there was the wave of isometrics, And we don't have one type of contraction that is superior to others. We should use all our toolboxes, different types of contractions for different phases. We make that case in the paper, talking about the different phases of rehab. We try to give also guidelines for progression from one stage to the other. We try to do as evidence-based as possible. So take a look at that. I think it can help you a lot in terms of looking how to progress with the management of the load, and also addressing the kinetic chain factors that are often neglected. So the musculature of the quadriceps, the glutes, they are very important synergists of the plantar flexors. So don't forget to manage, to look into that and manage the patients addressing those aspects as well. But going into your question now, adjuncts, they're a very controversial topic. And some people actually say they shouldn't be called adjuncts because they might be just as good as exercise. There's a big debate around that. And what I would say is I don't like that specific direction that some people like to go, because there's no comparison between improving structure of the tendon by progressive loading, doing education and progressive loading, in comparison to doing a passive treatment that just sticks a needle into the tendon and then, oh, both patients got better in the short term, so they're both equivalent. There's no way you can actually make that simplistic assumption. It makes no sense. But some adjuncts might be helpful. Some adjuncts might be useful to accelerate the process. So if I want to have a more expedited treatment that addresses an athlete that needs to go back to sports, needs to go back to running, needs to go back to basketball, soccer, whatever, what should I use as an adjunct? So I was very fortunate to have Alex Scott help me with this section. So he did a very nice systematic review to look into everything that exists in terms of placebo-controlled trials. So what do we know that improves more than placebo when you introduce that with exercise, without exercise, whatever, but what has been tested against a placebo? Because anything that hasn't been tested against a placebo can cause improvement in symptoms by a variety of reasons. So you don't really control for the confounding factors. You don't really know if it works or not. If it's a case series, if it's just a case report, you have no idea if that works really in relation to placebo. But what do we have as placebo-controlled trials? So that's what the table is about. This table has all the papers that we found that are placebo-controlled trials. And then we were careful to include two things, the possible mechanism of effectiveness and also the potential side effects. Because it's very important for the clinician that wants to add that to know and do a risk balance, a benefit balance to see, well, this might be the side effect, but the benefit might overcome the risk. So I would like to try this. So we included all those topics in there. And we also mentioned what works, what doesn't work, what has an RCT, at least one RCT showing a good result. And what we found was that there's not much there. There are very few interventions that actually do provide any benefit in addition to exercise or in isolation. What we found was from the electrical modalities, radio shockwave. There's one study that found a good result from Rasmussen in 2008. We mentioned the paper there. They found a good result from radio shockwave as an adjunct to exercise for mid-portion Achilles tendinopathy, but not for insertional. Only for mid-portion, it seems like the radio shockwave can be an adjunct. It can help to improve the outcomes of pain and function. The other interventions for the electromodalities, none of them could give us any indication that it could be helpful. In the clinical practice, we often use like laser therapy because it's very quick. There are a few studies showing that if you use 904 nanometers, the infrared laser therapy, that can sometimes reduce pain for patients who are very, very symptomatic, are not tolerating exercise. I usually use that in the clinic because it's very quick. It's like 2 minutes. You can have the intervention completely delivered in 2 minutes, and then you can have exercise right after that. So to me, in terms of cost and benefit, it makes sense, but the literature is not very good to support that in terms of robust evidence. So there's not much there. The indication of adjunct would be mostly if you have 12 weeks of exercise-based intervention and education and you haven't had a good result. then you should consider including other treatments. In clinical practice, we often do that anyway to try to reduce their pain and to allow them to exercise. But what I would recommend is just look at what the evidence says, look at what makes sense, look at the risk-benefit ratio there, and see what makes sense to use with your patient.
Risk-benefit ratio for injections, PRP, saline, cortisone, or corticosteroids. What did you all find there?
That's tricky too. So I don't know how it's in your area right now, Chris, but in Brazil, it's a huge wave of corticosteroid injections now. When I was in Delaware and when I was in Australia, PRP is very popular in these areas too. PRP is not very popular here in Brazil yet. I don't know if it's because it's not regulated by the regulating agencies. Some people are still using it just for research purposes. But in Australia and in the US, these treatments were huge when I was there. It was very common to see people being recommended to do that in the initial stages. They just arrived, first time tendinopathy. They didn't even go to rehab. They just go straight into an injection, PRP or something else. And then you dive into the literature. We find systematic reviews concluding very, very strongly PRP no better than placebo. So unfortunately, that's not a treatment that helps. I would very much like to say this is the magic bullet. This is very good. You should use this. But we have to be, like Charles Darwin says, we have to have the heart of stone. You have to look at the evidence clearly and what helps, what doesn't help, what is just propaganda, what people are just saying a lot, what people are trying to sell as good treatments, and what actually has been tested to show benefits to the patient. And PRP doesn't work. We saw systematic review doesn't work. We looked into other adjuncts. So corticosteroids are a very strong intervention as well, very, very popular here. Like I said, there's a good study from the Danish group that showed benefits for corticosteroids. If you don't have good results in the short term, corticosteroids injections have been recommended, but I have to make a very strong statement here. They don't do it in the tendon, guys. They do the corticosteroid injection, and I explicitly said that in the paper. They do it in front of the tendon in the Kager fat pad region. And I actually saw them doing that. I was there in Copenhagen. I saw them doing that. And that's the distinction that needs to be made. When we inject anything into the tendon, like you do a cortisone injection in the tendon, we have systematic reviews already saying that there's a lot of deleterious effects in the tendon from using cortisone directly in the tissue. So yeah, the review that I would suggest is published by Dean in 2013. They talk a lot about how using cortisone in the tendons has a significant deleterious effect. So be mindful of that. If you are going to use cortisone, use it in cases where the conservative treatment was very well conducted and it didn't work out, and then use it in the anterior aspect of the tendon, in the Kager fat pad, not in the tendon directly. That's what we found. So there's one study that talks about that has good quality. That should be you should keep that in mind as one alternative. If I recall it correctly, they had over 100 patients in that one. It's published in a very good journal. So that's one of the few interventions that we found that can be helpful. But be careful not to do the injections in the tendon itself.
When it's injected into the fat patch, the Kager triangle, what's the thought process as putting it in there in particular out of any other area outside of the tendon? And this is my own just, not understanding it, but does it not kind of leak into the tendon as a whole? What's the difference?
Yeah, that's a great question. And the honest answer is we have no idea. It's been injected in tendon since the 80s, and people get better very, very quickly. Their pain goes away, and then they go back to doing their activities. And then they hurt again, then they overused and they rupture, because you have the recipe for disaster. The patient has no pain and their structure is completely altered. And the cortisone inside the tendon actually alters the structure. It causes necrosis in some cases, disorganization of collagen. So it's bad for the tendon when you inject it directly into it. But apparently, from what they saw, injecting in front of it, it reduces their pain as well. It allows them to do progressive loading exercises, and apparently it doesn't give the potential side effects as hard as from an injection directly into the tendon. With that said, we have no idea if that's true. We would have to do long-term studies that would actually look into the structure to see if doing one way versus the other, you have more benefit in relation to the other. We don't know. Everything that I'm saying here is speculative. It's from what we think happens, but that's what they've been doing there in Copenhagen. So when they try 12 weeks of intervention, the patient's still very, very symptomatic. They're far from what they want it to be. The VISA score that goes from 0 to 100, it's below 70. They're still very bad in terms of function. These patients often receive a cortisone injection in the Kager fat pad region, and then they undergo more weeks of intervention to see if that causes the good result. And it's always paired with education. They always emphasize, please don't go running a marathon the day after because you're feeling great. Because if you don't give education, it's very often that people will love the treatment because the pain will go away and they will go back straight into doing what they want to do. They'll push themselves hard and harder, and then eventually they might rupture. So if you are going to use it with education associated with it, and always with a loading program associated with the treatment.
Topical treatment, and we'll kind of combine it as well, oral NSAIDs.
Yeah, it doesn't help. Just to give you a brief answer, there's a good study from the Danish group. Again, they picked up patients. That's very cool to see, actually. They picked up patients that had acute symptoms, less than 3 months. So let's see if those guys will get better. And they gave them, it's a randomized controlled trial, they gave them NSAIDs, and one group received placebo, the other group received the NSAIDs. And they both groups received the same treatment. So it makes sense to think, well, they're going to have less pain. They're going to have a greater tendency to exercise because they're not feeling as much pain in relation to the placebo group that's not receiving any active drug. And then they compare the outcomes in different time points. No difference between groups. You even using anti-inflammatories in people with acute symptoms, thinking that you're helping because you're going to accelerate the process, they're going to be more susceptible to adhering to an exercise intervention. Not true. They just as good. If you just do exercise intervention without the medication, they will get better the same way. So we've tried that for decades. NSAIDs were prescribed ever since the first caveman hit the other caveman in the head. I'm kidding here, but of course, since the 80s, that's the go-to treatment. They called it a tendinitis. They gave anti-inflammatories. People get better in the short term. As soon as they load it, they get worse again. So it doesn't help. And I would also like to point out that NSAIDs are not completely innocuous in terms of collagen synthesis. Some studies from the Danish group also show alterations in collagen synthesis associated with using NSAIDs. So it's not just a treatment that reduces their pain, and it doesn't have any side effects. They have side effects in terms of gastrointestinal issues as well, bleeding. Ibuprofen has a serious complication associated with bleeding in the gastrointestinal tract of these patients. So be mindful. If you're going to use it, like I said, risk, benefit, see the balance. If it makes sense to your patient, if it's supported by the evidence, then use it.
Before we dived into some of these options and adjunct treatments, you gave the caveat of how important it is to have these placebo-controlled randomized trials. Has that been done in exercise? And is that even possible? And are we comparing apples to apples?
That's beautiful. So that's such a great question. And Greg Lehman talks a lot about that. He says that we don't really put exercise to the same standard in relation to other interventions because we assume that exercise makes more sense, then we don't have to hold it to the same standard. And I partially agree with him. I think that actually does make sense. But we have several studies that compare exercise to wait and see. We have studies for gluteal tendinopathy that compare the exercise intervention to the tendon in relation to what they call placebo exercise, which would be exercise not focused on the tendon. And he's right in saying that when you look at the numbers, both groups get better. Both groups get better, even if you do a placebo associated intervention. It's not the focused intervention for the specific tendon, but it's hard to do that because like the placebo exercise group received exercises that also involve muscle contraction, that also addressed some kind of load for the tendon. And then how do you really differentiate that? And you see studies with only 12 weeks of follow-up, and then you don't really get the benefit of long-term that exercise gives, which is improving the structure, improving the neuromuscular aspects, improving the self-efficacy of individuals. So you have several benefits from exercise. And it's very hard to do studies that do a placebo intervention to control that. So that's a limitation that we still have. And with that said, it's still the best intervention that we have, the best one that actually gives us long-term results, that improves pain, reduces pain, improves function, and at the same time increases the robustness of the musculoskeletal system. We're strengthening the muscles. We're dissipating the load better. We're using strategies for education for the patient to be more have more self-efficacy. So there are several interventions that I agree haven't been tested with the same rigorous method than other interventions, but still from what we look from the big picture is still the best that we have.
And then for surgical options, what does the evidence suggest whether it's helpful or not, and what would those potential surgical options be?
Yeah, I'm not the expert here, so what I can say is what I work with other people who do that, and from what we have in the paper from our surgeons from New York, and what basically they do, they try to do some debridement of the area that has been considered altered. They often do some debridement of the parts of the bone that are compressing the tendon. So if you have some kind of exostosis, if you have a Haglund, that should be addressed surgically in some cases. If you have a Plantaris tendon, that is one very strong case that would get better with surgical intervention. But for your classical Achilles tendinopathy that has pain in the mid portion or in the insertion, it's not getting better. You've done 1 year, and that's one thing that should be mentioned. The recommendations from systematic reviews is you need to try conservative interventions for at least 12 months before you consider a surgery. There are systematic reviews on this topic. We should be emphasizing that. We shouldn't be doing surgery because somebody has done 12 weeks of rehab, because sometimes they just do passive treatments and they just poke the tendon and they don't really do any exercise-based intervention. Conservative treatment failed, let's do surgery. That's not how it works. That's not what the evidence says. We should be at least 12 months of intervention. They actually compare that to sham surgeries. That's a good systematic review as well. And they see the same benefits with conservative interventions in comparison to sham surgery, in comparison to actual surgery for tendinopathy. So we have good evidence to support that we shouldn't be doing surgery early on. We should be waiting for at least 12 months. And then if we do decide to do that, it makes sense to do a surgery that has been tested for in relation to other interventions. So take a look at what we mentioned in the paper. They mentioned some good promising treatments nowadays that they call, I forgot the name. Let me just quickly check here. They mentioned it's IONT. It's Achilles in-office needle tendoscopy. It's an emerging surgical strategy that they mentioned that they are having good results with it. It's less invasive than the actual interventions that have been described. So I don't have any experience with that one. I haven't seen that here in Brazil yet, but in the US they're trying this new intervention. They're doing some studies with that, so it makes sense to keep an eye open for that one. And then we also mentioned briefly in the article the post-op management for some of these most common conditions. So if you have a patient that has been submitted to a surgery, take a look there. There's a general overview of what you should do, and we also link to the references.
All right, last question, Rodrigo. We've gone through a lot. I appreciate you sticking it out. We're over an hour in, but last question. Out of curiosity, what has changed the most for you in regards to your understanding or treatment of Achilles tendinopathy?
Yeah, that's a great point for us to discuss, because whenever somebody asks me this, I always say I'm very optimistic about the future of our profession, our management of tendinopathies in general, because although it's a very challenging condition, it's very hard to manage, not just for us. If you look into the long-term studies from the European Football Association, there is a study from 11 years of follow-up. You see that they have 30% of recurrences. It's not hard just for you, the clinician that is seeing the Mr. Smith from around the corner. It's hard for everybody, but it's getting much better nowadays. Now we know a lot more than we did a few years ago, 10 years ago, 20 years ago. Like I mentioned before, the study 1984, the study by Clemens et al. Is really very interesting for you. I encourage you all to look that up. It's from the American Journal of Sports Medicine. It's a classical review paper. They just go deep into Achilles tendonitis, etiology, and treatment. And then you see ice massage being recommended. You see foot orthosis. You see interventions to correct pronation as being the most important ones. And then you see how far we've come in terms of understanding load better, understanding the importance of straining the tendon to get the structural adaptations. I certainly encourage everybody to read the papers from the group from Berlin, the Falk Measurement Studies. Adam Patsis' group does a fantastic job there. The Australian group, Peter Malliaras, Joe Cook, Craig Purden. The US group, Karen Suberdego is the queen. So we have so much great research. The Danish group, look at the evidence, look at heavy slow resistance, look at the different exercise protocols that we have, and look how far we've come. Before, we just used to treat symptoms. We were just technicians that could treat symptoms, that press buttons and put ice on painful locations, and then the patient would go back to doing some things, and then they would get worse, and they would go to a different practitioner. Nowadays, we really understand how to improve adherence, to provide education better, to give evidence-based practice interventions that really make a difference in terms of returning to full activity. So that's the reason why I'm very optimistic. And I think we have a lot of really great research coming in the next few years. So that's why I'm looking forward to the future.
I'm glad you're optimistic. I feel like some researchers come in and they're not nihilistic, but they're a little less hopeful. So I love the positive twist. Rodrigo, this was amazing. I'll link, obviously, the main primer paper, that 2015 JOSPT that you discussed about some of the secondary tendinopathy and rheumatological and all of I think that big table you mentioned and some other papers. Thank you so much for coming on. We'll call it there. For people that want to potentially reach out to you or learn more about your work, where can people go?
Yeah, great. So I'm most active on Instagram. So you will find me at @r_scattone, my last name. The problem is I talk about things in Portuguese because that's my main audience. So I try to do knowledge translation in Portuguese, but that's a good reason for you to learn Portuguese as well, people. It's a very important language. It's been one of I think the third, fourth more spoken language in the world. So good reason for you to learn Portuguese. I'm just kidding. I do a lot of posts in English as well. If you could just hit translate, you can see the posts in English as well there. But I've been trying to do knowledge translation there. I also have a Twitter account. So it's called X now, right? So X account is @Scattone Silva. You can find every time we publish anything new, I always make sure to post there so that people can know what we're doing. And that's the main way that people can reach me.
Perfect. Thanks again, Rodrigo. We'll call it there.
Thank you very much.